As you said, Andy, I'm Stephanie Worton. I'm a clinician scientist and honorary consultant obstetrician based in Manchester, where in the last couple of years I've been trying to set up my maternal microvascular group committed to studying the vascular dysfunction that we see in preeclampsia. And I'm really excited to share with you today some recent data that we've had. So we know from the two-stage model that the origins of preeclampsia start with a stress placenta that releases circulating factors, which affect the maternal system to cause the maternal phenotype where we see exaggerated inflammatory response and vascular dysfunction. And that vascular dysfunction is evident at all levels of the vascular tree, from the aorta down to the smallest arterioles, the capillaries, and throughout the venous system. But I spend my time studying small myogenic arteries because they hold a really crucial role. They are the key to perfusion because they can alter their diameter to control flow. For Sell's law here, Q shows us how important radius is in determining flow. And what's more important is that there are lots of them. So a small change in the diameter of small arteries has a really potent impact on organ perfusion and vascular flow. I like to use this analogy. The cardiovascular system has high central pressure, which perfuses the downstream vascular beds. The small arteries are the gates that can be opened and closed to control flow. If the gates are closed, the pressure remains high and the capillaries aren't getting perfused. In preeclampsia, despite all the pressure centrally and despite all the fluid in the maternal organs receive inadequate perfusion. And in this analogy, the endothelial lining of the blood vessels is the gatekeeper that controls the opening and closing of those gates. In preeclampsia, there's increased sensitivity to vasoconstrictors and impairment of endothelial-dependent relaxatory pathways. This causes vasospasm, which leads to maternal signs of hypertension and end-organ ischemia. Vascular dysfunction is largely ascribed to endothelial dysfunction. Endothelial dysfunction is the hallmark of PE. That's a sentence that I've said and I've heard a lot. But what does it really mean? Certainly, many markers indicating activation of endothelium or disturbance of its normal processes can be seen. And certainly, ex vivo arteries show clear impairment of endothelial-dependent vasorelaxatory mechanisms. But 30 years on, our efforts to treat endothelial dysfunction have not yet yielded a clinically useful therapy. And there's been relatively little consideration of the downstream effector, the vascular smooth muscle itself. But we've previously taken the approach of, rather than trying to fix the endothelial dysfunction, to try an endothelium-independent approach to bypass the dysfunctional endothelium, target smooth muscle directly to promote relaxation of maternal small arteries. We went on to show that the endogenous vasorelaxant factor kynurenine, which works directly on smooth muscle independent of the endothelium, causes substantial relaxation in arteries from women with healthy normal pregnancies and those with preeclampsia. We showed kynurenine has this effect by acting on the BK channel, the large conductance calcium activated potassium channel, that I'm just going to call the BK channel from here on in. And there's ongoing work by ourselves and Ant Karamanchi and Vincent Dupont to investigate kynurenine as a potential therapeutic for preeclampsia. But that's not what I'm going to talk about today. Because the kinks in the data are always the most interesting part of any study. And whilst we saw substantial relaxation in maternal arteries, both from women with normal-intensive pregnancy and those with preeclampsia, you can see here that the relaxation was reduced in women with preeclampsia. Now, there are problems with comparing these data directly because there are several ways in which these groups aren't matched, but this really captured our interest. The BK channel is a calcium-sensitive potassium channel in the smooth muscle membrane. When activated, it causes potassium to leave the cell, causing hyperpolarization and relaxation. Many things can regulate the activity of the BK channels, either by directly activating the channel, changing its sensitivity to calcium, but at baseline, the activity of this channel is determined by calcium sparks. Calcium sparks are highly localized, highly specific calcium jets that come from the ryanodine receptor in the sarcoplasmic reticulum and directly fire at and activate BK channels without increasing overall cell calcium. So what's already known about BK channels in preeclampsia? In a really established animal model of preeclampsia, the hypoxic sheep model, it's been shown that BK activity is reduced due to reduction in calcium sparks. But we are the first to ever measure calcium sparks in human pregnancy. And we hypothesized that this pathway of calcium spark to BK mediated vasodilation is altered in preeclampsia. To test this, we recruited women undergoing caesarean section who had uncomplicated normotensive term pregnancies or a clinical diagnosis of preeclampsia according to the ISSHP definition. As expected, women with preeclampsia delivered earlier and had significantly smaller babies than those without. We obtained mental biopsies at the time of caesarean section and isolated small resistance arteries with a diameter of less than 250 micrometers. These were loaded with a calcium-sensitive dye called Cal-520, which fluoresces in the presence of calcium. Arteries were mounted onto glass cannulae in a pressure myograph system and pressurized to 80 millimeters of mercury. We imaged them with a high-speed spinning disc laser confocal microscope and made video recordings, which were subsequently analysed with specialist software SPARCAN. And this is what we see. So firstly, in women with normotensive pregnancy, we can see individual, where's my pointer gone? We can see individual vascular smooth muscle cells, and within them, calcium sparks. So calcium sparks are named for their firework-like appearance, but I think they look a little bit like headlights on the highway going up the cells. Okay, so that's in normotensive pregnancy, and by comparison, in preeclampsia, there's much less firework activity, although you can see some other calcium events. There's a calcium wave going on here. The software objectively measures these, the number of active sites and the frequency of sparks at each site. So in preeclampsia, across the whole cohort, we saw a significant reduction in the frequency of calcium sparks. And unfortunately, that means I'm going to have to explain this pathway a little bit more. So I told you that at baseline, calcium sparks regulate PK activity, but what controls sparks? The answer to that is pressure. So within small arteries, increases in pressure triggers depolarization and opening of calcium channels, which causes constriction, and that protects downstream tissues from increases in flow and pressure. That's the myogenic response. But simultaneously, pressure activates a regulatory relaxatory pathway whereby oxidants activate PKG, causing the release of calcium sparks on the ranitidine receptors, which causes hyperpolarization and relaxation. Calcium is then taken back up quickly via circuit 2, which is also under the control of oxidant-activated PKG. So our initial experiment was performed at 80 millimeters of mercury and normal mean arterial pressure, and we went on to study sparks at a range of pressure. In normotensive pregnancy, shown here, spark activity is low at low pressure, but increases with increasing pressure up to 80 millimeters of mercury, where it reaches the ceiling, and beyond which no further increase is seen. This profile is comparable to that seen in human and animal arteries outside of pregnancy. By comparison, preeclampsia in red, calcium sparks are already reduced at low pressure, and there is a failure of the increase in calcium sparks in response to increasing intraluminal pressure. And across all the pressures tested, we don't see that rise in sparks that we would expect to see in healthy vessels. To investigate this mechanism, we assessed the amount of total calcium that was held within the sarcoplasmic reticulum calcium stores. And we did this by using a 10 millimolar dose of caffeine, which causes the sarcoplasmic reticulum to kick out all of its caffeine. So within the same experimental setup, so this is a normotensive vessel that's started to play. And in response to the addition of caffeine, we get a big flash, which is all the calcium being released from the sarcoplasmic reticulum. On the other side now in preeclampsia, we can see that after the addition of caffeine, we get a smaller flash in response to the caffeine. And analysis of this software, analysis of this by the SPARCAN software indicates that the amount of calcium released, measured either as the peak amplitude or as the area under the curve, is strikingly reduced in preeclampsia, suggesting that altered calcium handling in the sarcoplasmic reticulum may underpin the reduction in calcium sparks that we've recorded. So here, we've shown a reduction, I've lost my pointer again, here it is. We've shown a reduction in calcium sparks and in the sarcoplasmic reticulum calcium store in preeclampsia. As far as we know, this is an entirely smooth muscle pathway. It doesn't involve the endothelium. So I'd like to revise my earlier assertion that preeclampsia is an endothelial disorder to now say that preeclampsia is both an endothelial and vascular smooth muscle disorder. Excitingly, this discovery identifies potential druggable targets to improve microvascular function in preeclampsia. We've previously shown that the endogenous BK activators HBD2, which is a component of the innate immune system, and kynurenine, which is a tryptophan derivative, can overcome the calcium spark deficit to cause significant relaxation in arteries from women with preeclampsia. But what's more exciting will be to try to fix this deficit. Whilst we have, as you can see from the question marks, many other areas of this pathway to still study to fully understand this mechanism of reduced calcium sparks. We have seen changes in the calcium leaving the sarcoplasmic reticulum, and we've seen changes in the amount of calcium in the sarcoplasmic reticulum. And this has led us to hypothesize that the primary defect may lie upstream here in oxygen activation of PKG. If so, we may be able to intervene at this point with novel antihypertensives, which are currently under investigation within our group and by our collaborators, that directly activate PKG1 alpha, with the intention of fixing the underlying vascular deficit in order to not just bypass the problem, but to restore physiological control of the microvasculature in preeclampsia. So I'd like to thank all of my collaborators who span the microvascular group at Manchester and the maternal fetal health department at Manchester. I'd particularly like to thank Louisa Parnell, my PhD student, who should be Dr. Louisa Parnell by this time next week, and she's done a lot of the calcium imaging that I was showing today. I'd like to thank the staff and patients at St Mary's Hospital, without whom none of this work would have been possible, and to thank NIHR and now the University of Manchester, who support me,